Thanks, Dr. McLean. Thanks, everyone, for letting me speak today on post-prostatectomy erectile dysfunction. The objectives were circulated. That's okay. I'll get it. Okay. The objectives were circulated earlier. I won't go through them again, except let's just say the objective now is to deliver this coherently in the next 45 minutes or so. And I would remind the attendings that today is anti-bullying day, so keep that in mind when you make your comments at the end of the case here. So we all know that prostate cancer is very common. There are many modalities for treatment. In the United States, approximately 60,000 men underwent radical prostatectomy last year. We often define our surgical success by our margins, our biochemical status, and our surgical control is often at odds with functional outcomes such as incontinence and potency. In spite of advances in our understanding and technology, the range for recovery of erectile function following prostatectomy remains quite wide, as reported in the literature. This is in part due to problems with terminology, in part due to that it's a multifactorial problem. We'll discuss this more. We do know that it has a significant impact on patient and partner lives. It's the most important factor affecting health-related quality of life at 24 months post-procedure. It affects the everyday interactions with partners. Perceptions of sexuality may be even more important in young men, and is the greatest concern after morbidity, mortality, and incontinence. And part of the problem in determining how common it is that our terminology for it is quite vague. It's listed in the literature as described as potency or tumescence or the ability to attain erection, but we don't have any standardized, we're not currently using standardized terminology for this. It's often assumed in men preoperatively. The use of erectogenic medications often isn't verified or described. And the post-operative assessment may be different from the preoperative assessment, where men will sometimes be assessed with a shim score beforehand and then asked if they're potent afterwards, which is just the ability to attain erection. The timing of assessment post-operatively is important as well. So if we want to compare apples to apples, we have to really use validated questionnaires. And probably the two most common in use would be the SHIM, which is kind of an abridged version of the International Index of Erectile Function, 5 questions, or the EPIC questionnaire. And Schrock and his group in 2008 showed that a score of 59 on the EPIC questionnaire or greater than 19 on the SHIM score seemed to predict good sexual function, and they suggested that this replace the definition for potency, which currently is just erection sufficient for intercourse. This is nicely illustrated by a study by Budas and his group in 2009, where they looked at men 1 year following nerve-sparing prostatectomy. And what they found is that 92% of men were considered potent if you use the standard definition of ability to perform intercourse, whereas just 59% of these men were potent if you looked at a SHIM score of greater than 19. And so what we see is that potency in the literature will vary greatly by how it's defined. This was also shown by Menon and his group, and if you just focus basically on comparing the left and right-hand sides, you've got men who are rated on their return to baseline function versus their ability to perform intercourse. And you can see, we'll come back to this graph to illustrate a few more points subsequently, but there's a difference obviously between the two sides of the graph, and this isn't due to assessment terminology. It shouldn't be surprising if we look at the SHIM questionnaire. Question 2 would essentially be the definition for potency, the ability to attain erection sufficient for intercourse, and it really doesn't. The definition for potency really doesn't address a lot of the other domains of sexual health which are inquired on in the SHIM score. There are also some problems with the questionnaire in that it can be interpreted differently whether or not you have a sexual partner. So what we see is that erectile dysfunction is part of a larger picture of sexual dysfunction, which includes orgasmic dysfunction, changes in sexual desire, and altered partner relationships. And these are all impacted by our treatments for prostate cancer. It's important to keep this in mind when we're counseling our patients, that it's not just about the erection, but changes in orgasm. They'll have dry orgasms, but it may be decreased, absent, or painful. They may experience climateria. They often experience changes in sexual desire, and a return to actual baseline function following prostatectomy is quite rare. With regard to counseling on erections, you can advise them that this takes quite a long time, up to 3 years. It's dependent on a number of patient-specific factors that can be evaluated preoperatively, performed intraoperatively, and carried out postoperatively. They may notice changes in their penile length. There's been reports of associations with Peyronie's following radical prostatectomy in the literature, although no causal relationship has been found. and you can discuss options for penile rehab. And this should be discussed in the context of a partner if there's there, and they should be directed as a couple towards appropriate sexual resources. So as I mentioned, the problems for erectile dysfunction are multifactorial and can be broken into preoperative, intraoperative, or postoperative factors. Dr. McNeely made a nice summary of this. So we only have 5 things to talk about. Looking at preoperative factors, disease characteristics, patient partner and age, erectile status, comorbidities, and interest in sexual activity following are all going to be factors that play into the potency. If we're looking for guidelines for nerve sparing, obviously indications for nerve sparing or contraindications will guide our surgical management. These are somewhat vague. The most current guidelines from the EAU in 2011 essentially just comment that if a patient is potent preoperative and has low risk for extracapsular disease, you can proceed with bilateral nerve sparing. Unilateral nerve sparing can be considered in those who are potent preoperatively and have clinical stage T2A to C disease. And if we're looking for any of the kind of North American guidelines, these are older and even more vague, saying just depending on tumor characteristics and patient sexual function, nerve sparing or non-nerve sparing prostatectomy is commonly performed. So we don't really have a lot of strict indications here, and sometimes as a resident when we are looking for better definitions, we'll go to Campbell's. My apologies to Dr. Black. But Campbell's will say that nerve sparing is questionable when there's extensive cancer and or perineural invasion on biopsy, palpable extraprostatic tumor extension, PSA greater than 10, or a Gleason score on biopsy greater than 7. It's interesting because this definition, or these indications, have changed somewhat over editions, and just as recently as the 8th edition, any high-risk feature was considered a contraindication according to Campbell's for nerve sparing. Looking at other possible tools we can use to determine our nerve-sparing indications or approaches, Parton tables have been used by some groups to determine patients are either high risk or low risk for organ-confined disease. This has been used to determine nerve-sparing approach, whether it's intrafascial or interfascial, and we'll discuss these terms shortly. Catan nomograms have been used to use clinical features to predict site-specific extracapsular extension. My understanding is that this is what they're using in Seattle to guide whether wide or close to dissection of the neurovascular bundle. And other groups have kind of made their own approach. This publication by Tawari and his group builds on an earlier publication where they use kind of a modified Cornell algorithm, which they talk about using clinical features of the disease and adding MRI to it to assign patients to risks for extracapsular extension, and then targeting these different risks with different grades of nerve sparing procedure, one being a complete nerve spare that essentially stays right on prostatic capsule, being the most aggressive, to grade 4 where they wouldn't resect or they wouldn't preserve the neurovascular bundle at all. And so building on Tawari's publication, MRI is not new to preoperative staging or operative planning. This group in 2004 from Memorial Sloan Kettering used MRI, and they found that it improved the accuracy of the surgeon's decision to resect or preserve the neurovascular bundle. It supported the decision to preserve it in those patients who were low risk, and in the small group of patients they had who were high risk, they found that 78% of these patients actually had a more aggressive nerve preservation approach, and that this was appropriate on pathology in 93% of the cases. Similar, more recent studies have confirmed this. Most recently that I could see was in 2012 from an Italian study by Panabianco. So I'd like to show some nice pictures of functional MRI demonstrating the neurovascular bundles, and that would be nice to look at, but the role for MRI remains controversial, in part due to a wide range of diagnostic accuracy purported in the literature. And what this group by Preston and his group in 2013 showed is that recognizing the limitations of the literature for MRI in terms of its sensitivity and specificity right now, we can still use it as part of a tool in risk stratifying people. And so what they do in this, on the right-hand side of this slide, is they take a pre-test probability for extracapsular extension based on clinical variables using a Parton table. This man would have a 35% chance of having extracapsular disease. They then calculate a likelihood ratio, both positive and negative, for MRI based on the sensitivity and specificity reported in the most recent literature. And the likelihood of this man having extracapsular disease, if he has a positive MRI, is shown in the blue arrow, and that's about 60%. If his MRI is negative, then his post-op probability of having extracapsular extension is less than 20%. So you can see this might be important to discuss when you're presenting information to a patient and talking about MRI and talking about the options for nerve sparing, because there's a MRI can make a difference, even though we recognize that it has some limitations. Obviously, the intraoperative factors would trump approach based solely on something like this. Patient partner age or other factors that affect erectile function post-operatively. We can see that these are fairly favorable numbers, but for a young man between 40 and 50, their chances after bilateral nerve sparing have been quoted as high as 95%, and this decreases by about 10% per decade. Partner age has also been found to play a role, and those who have younger partners have been shown to have higher rates of erectile recovery. But some of those favorable numbers that I've just shown on the last slide should be probably balanced out by some of the other studies that have been seen in the literature. These are numbers taken from the prostate cancer outcome study, which is a large study initiated through the mid-90s. And they took a cohort of men from this study, about 1,600, who either had radical prostatectomy or radiation therapy, aged between 55 and 74. And they looked at the potency outcomes following procedure. And you can see in the red box here, 2 years after their procedure, just over 20% of men had an erection sufficient for intercourse. If you go out to 5 years, slightly more had it, but again, it dropped off by 15 years. The other interesting thing to see is that just over half of these men were actually bothered by their changes in erection 2 years out, and that this actually diminished with more time. So it's important to keep in mind these numbers and balance them with the numbers that I presented in the previous slide. Baseline potency and health, again, obviously play into post-op erectile function. More than 50% of men with clinically localized disease preoperatively have some form of erectile dysfunction. This is seen in the Menon paper, which I introduced earlier. You can see that men here have been stratified according to their pre-op shim scores. It's a little difficult to tell with the legend here, but the lower scores are generally the lower bars, and those men who had higher shim scores preoperatively tend to recover erectile function better postoperatively. Comorbid diseases are other factors that contribute to preoperative factors for erectile dysfunction. The intraoperative factors are probably the most important, and we've modified our surgical technique according to our advancements in anatomical understanding, and probably most importantly was the kind of the appreciation for the neurovascular bundle. It's been shown that potency following retropubic prostatectomy or radical prostatectomy exists on a continuum relating to the quantity of nerves spared. So on the right-hand side, where you spare more nerves and you have bilateral nerve sparing, this may just be temporary neuropraxial injury, whereas if you're doing bilateral neurotomies and bilateral neurovascular resection, your chances for erectile recovery are quite poor. The same idea formed the basis for whether nerve grafting could be used in these men who you resect a neurovascular bundle. Unfortunately, there's limited data on the effectiveness. The last randomized trial in 2009 really didn't show any benefit. And the critics will argue that the disease characteristics that lead you to resect the neurovascular bundle on one side or both sides actually probably predispose you to getting adjuvant care that will nullify the potential benefit of having a nerve graft anyways. Accessory pudendal arteries have been found in up to three-quarters of men undergoing prostatectomy. They may provide unilateral or bilateral arterial supply to the corporal bodies. They can be solely responsible for all the arterial supply here, so it's important to preserve these if identified in order to prevent arterial insufficiency. This was shown by Rogers and his group in 2004, where they took 40 men who they identified accessory pudendals in and matched them to a group of controls according to their age and disease status. And you can see the solid line shows that men who had their pudendal arteries, accessory pudendal arteries preserved, had a faster return to potency based on this Kaplan-Meier assessment, and actually a better return to potency overall. So the main study, the main kind of contribution foundation from which we've based our nerve sparing procedure is from the work done by Walsh and Donker in 1982. And what they had done is they looked at their last 30 radical prostates and found that just 5 of them were potent, and they wondered what was contributing to this. They did cadaveric dissection on male infants and found that there was an autonomic innervation to the corporal bodies, and that this was probably responsible either during the apical dissection or transection of the lateral pedicles for the impotency following the procedure. They later characterized the neurovascular bundle as a macroscopic landmark you can use intraoperatively and laid the basis and showed that preserving these structures contribute to potency post-operatively. So these were the anatomical ideas that they would have initially had. You can see that the autonomic innervation coming from the pelvic plexus is shown as a discrete cavernosal nerve traveling on the posterior lateral aspect of the prostate, penetrating the urogenital diaphragm and integrating the corporal bodies. This just compares post-op, pre-op and post-op images for the same thing once the prostate is removed. And you can see that early on, the cavernosal nerve is described as quite a discrete structure traveling on either side. But our understanding of the pelvic anatomy and the neurovascular bundle has increased over time. There still are quite a few questions here. But what we do know is that autonomic input from the sympathetic system comes through the hypogastric nerve through branches T12 through L2. That the parasympathetic branches come from anterior branches of S2, 3, and 4. That these autonomic inputs converge at the pelvic plexus before distributing what we obviously would expect innervation to the pelvic organs. And importantly, that the pelvic plexus sends out a neurovascular bundle which not only innervates the corporal body and the prostate, but also has fibers innervating the levator ani and rectum. So there's much more complex, intricate anatomy than once appreciated. In addition, we can't quite see the neurovascular bundle here, but instead of being a discrete cord-like structure shown on the last diagram, Tekanaka in his group in 2004 described it as being much more fanned out near the base of the prostate, much more discrete and cord-like near the mid-prostate, and again fanning out near the apex of the prostate. So there's great variability in its course. This was developed more by Eichelberg and his group in 2007, who felt that the prostate was probably encapsulated in nerves rather than having nerves running discretely beside it. What they did is look at prostates from 31 non-nerve sparing specimens, and what they found is that 80% of the nerves occupied the position we would expect to see where we traditionally know the neurovascular bundles to lie at about the 7 o'clock to 9 o'clock position. Interestingly, though, they found that just over 20% actually occupied the anterior surface of the prostate. Now, the functional outcome or the functional purpose of these nerves weren't known, but it was interesting to know that nerves are actually running around the entirety of the prostate. This really laid the foundation for validating the high anterior approach, or releasing the neurovascular bundle high up anteriorly on the prostate, and this is known by a number of terms: the curtain dissection, incremental nerve sparing, or Menon's group calls it the veil of Aphrodite for the Greek goddess of love and beauty. But his group showed up to a 97% return of potency at 1 year, and unfortunately this hasn't been replicated by any other groups. Costello's publication in 2010 would seem to challenge this. They did agree that the anterior surface of the prostate was covered with a considerable amount of nerves, but on immunohistochemical staining, they found that just 15% of these were sympathetic nerves and just over 5% were parasympathetic nerves. Based on this, they felt that these nerves were likely not a major factor for erections, and proposed that the reduced rates of, or the increased rates of potency following prostatectomy using the high release was probably due to reducing neuropraxial injury due to reduced traction, reduced thermal injury. They also suggested that the neurovascular bundle itself was compartmentalized by fascial bands. You can see in this overlay here that the fascia of the neurovascular bundle is divided by what's highlighted in blue here. The prostate itself is green in this diagram, the rectum is gray. And they noted, interestingly, that the most medial fibers, or the ones most towards the right side of the screen, were the ones that carried the highest percentage of parasympathetic fibers. And they wonder whether this means that the cavernosal nerve, the actual nerve supplying innervation to the corpora, travels as a discrete entity within the neurovascular bundle. So these two terms, neurovascular bundle and cavernosal nerve, probably shouldn't be used synonymously. So we've almost come full circle. What I've said, it's not as simple as a cord-like structure beside the prostate, and then basically said Costello says it is almost as simple as that. Given some of the variation and ambiguity in the anatomy, Walls and his group tried to do a critical synthesis of what was available in the literature for anatomy, and what they eventually came upon is the anatomy is complex. It has very significant variability between individuals. With regard to the neurovascular bundle, it's made up of a plentiful supply of nerves, a scaphoidal vein and arteries, synovial and adipose tissue. It covers the surface, the posterior or lateral surface of the prostate, very close to the seminal vesicles. It can be affected by prostate size, and it occupies spaces between the fascial layers of the prostate. And they also say that the fascial layers are multi-layered, fused in some areas, and well-defined in other layers. And ultimately, they conclude that better knowledge anatomically leads to better oncologic and functional outcomes. And for the benefit of the residents and myself here, we'll quickly go through some of the fascial planes here using images from Wall's paper here. Looking first in an axial view of the mid-prostate, we can see in red here the endopelvic fascia is highlighted. The prostate's obviously in the center, and this is taken at the mid-prostate level. The first important structure to note is the endopelvic fascia covering the anterior part of the prostate. This has been described as the visceral endopelvic fascia, and its counterpart would be the levator ani fascia, or what's called the parietal endopelvic fascia. Some people don't distinguish between these two layers, visceral and parietal, but in the publication by Walls, they do. These two layers meet at the fibrotendinous arch of the pelvis, and that's the whitish band that we see when we clear off the endopelvic, stretching between puboprostatics and the ischial spine. You can see the distribution of the neurovascular bundle deep to these structures I've just highlighted. De non-biliaris fascia is posterior and separates prostate and rectum. And the prostatic fascia, again, is deep to the endopelvic fascia that we've highlighted here, and together with the endopelvic fascia makes up what's called the periprostatic fascia. Some people call it the peripelvic fascia. You can see there's a lot of names, a lot of different names for the same structures, which make it a little confusing. But essentially, anteriorly, the periprostatic fascia is made up of the prostatic fascia and the visceral endopelvic fascia. Laterally, it's made up of the prostatic fascia and the anterior endopelvic fascia, and posteriorly, predominantly, it's de non-biliaris. The deepest structure is the prostatic capsule, which maybe isn't a true capsule in the true sense. It's indiscernible from the actual stroma of the prostate, made up of fibromuscular fascicles, and is actually absent anteriorly at the apex and at the base of the prostate. This is just another slice more distally, looking through the sphincteric urethra, and it shows what we would consider like a traditional location for the neurovascular bundle at about the 5 and 7 o'clock position. This is a slice through the base of the seminal vesicles, and again, it's just important to appreciate the proximity of the neurovascular bundle and pelvic plexus to the seminal vesicles, and keep this in mind during your dissection. Looking at a coronal view of the prostate, we can appreciate the vascular pedicle, which we have to control, preferably with clips or sutures when we're performing nerve sparing. This is embedded to variable degrees, as I've said, through the prostatic fascia, which is deep to the endopelvic fascia, just to reiterate. On the final view here, this is essentially just to illustrate de non-biliaris, which is felt to be an obliterated embryologic peritoneal space, and it extends essentially down to the apex of the prostate. So the take-home message to keep things simple is that the exact anatomy of the fascias and, of course, the neurovascular bundle is still being teased out. For simplification purposes, if we're going superficial to deep towards the prostate, you have the periprostatic fascia composed of endopelvic, which is either broken into visceral or parietal or not at all. Deep to that, you have a layer of prostatic fascia, which is the fascia that embeds the neurovascular bundle, and then you have the prostatic capsule deep to that, all of that. So with that, we can now look at the terms intrafascial, interfascial, and extrafascial approaches for nerve sparing. So in the intrafascial dissection, you're essentially coming through the visceral endopelvic fascia on the anterior of the prostate, and you're hugging capsule all the way around posteriorly and leaving de non-biliaris behind. Obviously, this has the best outcome for preserving the maximal number of nerves, but the greatest risk of compromising oncologic outcome. If you're looking at interfascial, this would be the classic nerve-sparing procedure that we're taught. You make an incision through the parietal endopelvic fascia outside of the fascial tendinous arch of the pelvis. You carry this dissection out before coming back through the endopelvic fascia at about the 5 o'clock position and excluding the neurovascular bundle laterally. you will then come back through de non-viliers and take this out with your specimen. And finally, with an extrafascial approach, obviously this has the least potential for potency recovery afterwards. It's a wide resection that basically takes all of the periprostatic layers with it. So there's been a number of techniques, kind of, or ideas to identify the neurovasculars intraoperatively. Oftentimes you can see this as a macroscopic structure, but bleeding and other surrounding tissue sometimes makes it difficult. So most of the residents here have probably seen something called the cavern map. This isn't widely used, given that critics voice low specificity. This was mostly a slide for Dr. Goldenberg and Dr. Glave, who aren't here, but shows their randomized phase 3 study with cavern map demonstrating in men who had this used during their nerve sparing procedure, they actually had a significant increase in nocturnal tumescence measured by the Rigiscan device. Unfortunately, they didn't find any significant trend in improved function on validated questionnaire post-operatively. The use of truss and Doppler ultrasound, especially applied to robotics, is becoming more prevalent. Ultrasound elastography has been shown to detect extracapsular disease. There's optical coherence tomography, which is being applied because it has higher resolution than ultrasound. And the last option is using a retrograde nerve tracer and an intraoperative microscopic device that images where these nerves actually are. The bottom line is that there's no good options yet. This just shows the application of Doppler ultrasound and transrectal probe with robotics. You can see a 3D rendering of the prostate and the Doppler signals indicating where they think the neurovascular bundle is. This is a fully registered image that a surgeon would see on his console, where he can control the Doppler probe, see the anatomy inside, and operate real time, seeing both ultrasound and gross images. And you can see on this in this image that you can actually see the scissors that are intercorporeally there. A discussion about whether open or lap or robotic approach is better is warranted, and the short answer is that the approach really doesn't matter, at least from what we can see in the literature. There are many approaches with variations of technique based inherent to each modality. So far, there's no clear winner, and it's probably more important just to adhere to the basic anatomic principles and surgical principles when performing a nerve sparing procedure. This is shown by Berryhill and his group in 2007. It's a slightly older study which is focusing more kind of the early 2000 era, but essentially they compared 7,000 men who had undergone nerve sparing procedure open to 4,000 who had it lap to 4,000 who had it robotic. And they cited the same difficulties in interpreting and looking at the literature based on terminology and assessing outcomes, but they didn't feel that they could note a significant difference in outcomes based on any of these modalities. In a more recent systemic review, Fakera and his group had the same concerns in looking at the literature in terms of assessing outcomes, but they weren't able to demonstrate a significant difference between open, lap, or robotic either. They did find some studies that seemed to suggest a faster recovery of potency with robotic versus open, but no significant differences overall. The push for minimally invasive procedures and the benefits patients are derived in terms of perioperative morbidity were recognized by Galvin and Eastham, and this prompted them to have a look at the open radical retrograde prostatectomy and do a review of outcomes. They noted that open surgeons have been challenged by these procedures to decrease the length of their incision, decrease hospital stay, analgesia requirements, blood loss, while preserving their functional outcomes. And they felt that it was reasonable to say to patients who are having bilateral nerve sparing that 60 to 80% of them will regain potency. Because of some of the advancements that have been pushed to open surgery from the minimally invasive techniques, they felt that open surgery remains the gold standard by which functional and oncologic outcomes can still be compared. Surgeon experience is another aspect. Ratha and his group in 2008 looked at 800 men done by a single surgeon. The first 250 had erectile recovery of on the order of around 60%, whereas his last 250 patients had better than 75% recovery of erectile function. Centers of excellence have been reportedly to have greater returns of potency versus other urologists. However, one high-volume center in the United States looking at this said that you can't necessarily gauge surgical expertise simply by volume, and this may hold some weight with nurse sparing. So, based on the fact that open laparoscopic robotic approaches haven't been shown to have much difference between one another, we know our anatomic principles. It's probably important just to define some of the critical steps of nurse sparing. When you're doing an open procedure, that you should be doing this with a headlight or loops to improve visualization. Accessory pudendals should be identified and preserved. The hemostatic control of the DVC should be adequate such that visualization for the remainder of the case isn't a problem. We've seen that traction and thermal energy should be avoided, especially near the apical dissection and the seminal vesicle tips. The neurovascular bundle distally should be released prior to any anterior traction of the prostate. Proximally can be released after we get the plane between rectum and prostate. And hemostatic sutures or clips are preferable to thermal devices for taking the lateral pedicles. So as we get towards the end of the talk, the last kind of portion to consider postoperative factors. And it's important when we're looking at postoperative issues that we consider both the issues preoperatively and intraoperatively that each patient presents with when making a treatment plan. It's important to involve the partner early, and the eroticization of erectile aids has been shown to improve compliancy and possibly outcomes in the long run. And really the role of counseling shouldn't be understated in these men. The consequences of neurovascular bundle injury were nicely described by Dr. Bella when he was here visiting as a professor. In summary, the downstream effects of cavernosal injury are a penis that's chronically flaccid. You get tissue hypoxia, smooth muscle atrophy, and apoptosis, cavernosal fibrosis, and the result is veno-occlusive dysfunction. The idea of penile rehab has been kind of born out of this, born out of these consequences. And penile rehab is really just the use of any medication or device used to speed the recovery of erectile function. The strategies attempt to basically target the negative consequences I've just described. It's to improve cavernosal oxygenation, promote endothelial function, and prevent structural changes following cavernosal nerve injury. And there are a number of methods to go through this. The idea of penile rehab could be a rounds unto itself. And so we'll just quickly go through the options. First-line agents are typically the oral phosphodiesterase inhibitors, which, if you look at this slide, have up to 70 to 80% efficacy. Second-line agents would include, as Dr. McNeely discussed, the intraurethral suppositories, vacuum devices, or intracavernosal injections. And for men failing these treatments or a combination of these treatments, you can consider penile implant in men who are aggressively seeking erectile function. Looking more closely at the basis for phosphodiesterase inhibitors, the mechanism behind why people think these would have an impact. In rats, we've seen that they can increase the cavernosal smooth muscle to collagen ratio and increase expression of nitric oxide synthase in penile tissue, thus preventing negative changes. They've been shown in men to preserve corporal smooth muscle following prostatectomy, and they've been shown to promote endothelial function or mitigate endothelial dysfunction in men who are post-radical prostatectomy. But these are in vitro studies or animal studies. So the question remains, are they worth it? So on the one hand, there's good evidence that loss of nocturnal and spontaneous erections leads to deleterious effects in the corporal bodies. Current best practice would say that we should be using PDE5s pretty much as soon as the catheter comes out. Against this would be the cost of these agents, the side effects, and the lack of clinical evidence showing benefit in human on the ultimate outcome of erectile function. And further to this, there remain a number of unknowns here. How long should men be treated? Who are non-responders to these, and how do we identify them? And how do we triage them through other modalities of penile rehab? Is daily better than on-demand? And the most recent and largest study on this would probably say that on-demand is no different than daily. And is any one agent superior to any other ones? And these are questions that need to be answered. So in the most recent review that I could see in the literature for this by Saloni and his group, they acknowledge that there's a lack of evidence confirming the benefit for penile rehab, but they still say that rehab and treatment of some type is better than nothing. They suggest starting rehabilitation of any form as soon as possible, a PDE5 inhibitor as soon as the catheter comes out. They again underscore the importance of psychosocial and sexual counseling. They recommend that people consider testosterone replacement in select men who are hypogonadal following prostatectomy. They again reinforce the role of penile prosthesis in certain men and recommend further research. So to conclude and summarize, ED following prostatectomy remains a significant complication following surgery, in spite of advances in our understanding of the anatomy and technique. There's no single surgical technique or approach that has convincingly demonstrated superiority over any of the other ones. Post-prostatectomy erectile dysfunction is multifactorial, has a significant impact on patients' quality of life. Penile rehab should be instituted and should be instituted in a multimodal fashion with kind of a backstop of counseling. And this is a field where virtually everything is a moving target and research is needed in virtually every aspect. So with that, I'd just like to thank Dr. Black for reviewing the slides beforehand, and if there's any questions, I can answer those.